Welcome to this case review on neonatal ventilation troubleshooting. We will cover key concepts like PCSIMV, the VN500, leak compensation, and clinical problem solving. I'm Dr. Salem from the Neonatal Intensive Care Unit. Let's review this ventilator graph. Panel A at the top shows a scenario where automated leak compensation is OFF. Notice the flow and volume waveforms and the low VT per kilogram body weight of 2.4 milliliters per kilogram. What do these waveforms and numbers tell you? The problem here is a large endotracheal tube, or ETT leak. In panel A, with leak compensation OFF, the measured exhaled volume, VTE, is falsely low at 3.6 milliliters, even with a 68% leak. The clinician might think the VT is adequate. With leak compensation ON in panel B, the system calculates the real VT reaching the lungs as 6.8 milliliters, reflecting true ventilation. Always activate leak compensation if the ETT leak is significant, around 20 to 30% or more, to avoid under or over ventilation. When troubleshooting a recurrent low VT alarm or not reaching the target tidal volume, consider possible causes like decreased compliance, ETT obstruction, or a large ETT leak. Suggested actions include evaluating breath sounds, examining ventilator waveforms, repositioning the patient or ETT, and obtaining a chest X-ray to rule out pneumothorax or atelectasis. To recognize and resolve an ETT leak, first look for a high percentage leak on the display and observe if the flow returns to zero and if the volume graphic appears flat. With compensation off, a low VTE reading can be misleading. Enable leak compensation to calculate the true VT. If the leak persists, recalibrate the flow sensor. Clinical action may include increasing VT or upsizing the ETT if the leak is severe. If the ventilator is not generating peak inspiratory pressure or PIP, consider scenario A, no PIP generated, usually caused by tubing disconnection or a VT set too low. Immediately check all circuit connections and reevaluate the VT setting. For scenario B, low PIP not rising, suspect a complete ETT obstruction. Check for ETT obstruction, kinked tubing, or secretions requiring urgent suction. Never adjust ventilator settings without first auscultating and inspecting the circuit. Troubleshooting high CO2 involves a systematic approach. First, review the baby clinically, chest expansion, breath sounds, and color. Second, confirm the set exhaled tidal volume is delivered. Next, check for an ETT leak, but do not raise the maximum pressure before repositioning the infant. Assess chest expansion adequacy and rule out ETT displacement or obstruction with a chest X-ray. If a pneumothorax is suspected, perform an emergent chest X-ray or transillumination. When troubleshooting low carbon dioxide or hyperventilation, actions include decreasing VTE, decreasing the rate in SIMV mode, or increasing PEEP. Also, lower the trigger sensitivity to reduce auto-triggered breaths. Consider metabolic acidosis, as the patient may be compensating. Check for water in the circuit and ensure patient comfort and positioning. A systematic approach to low SpO2 starts with reviewing the baby. Exclude air leaks and assess for worsening respiratory distress syndrome, which may require additional surfactant. Consider persistent pulmonary hypertension of the newborn. Then, acutely increase the fraction of inspired oxygen. If VTE is not delivered, increase the maximum pressure, check for a displaced or obstructed ETT, and exclude congenital heart disease. Finally, consider changing to high-frequency oscillation, obtaining a chest X-ray, or performing a blood gas analysis. For a low VTE alarm, causes include a large ETT leak, pneumothorax, or poor compliance. Identify the cause first. Do not blindly raise the maximum pressure. For a persistently tachypneic baby, the causes are a VT set too low or agitation. Actions include increasing VTE by 0.5 to 1.0 milliliters per kilogram, even if the blood gas is normal, and addressing sedation needs. For persistently low PaCO2, consider metabolic acidosis compensation. The respiratory center responds to pH, so check pH and ensure comfort and sedation if needed. This is a quick reference summary of problems and their corresponding causes and fixes. For a low VT alarm, consider compliance, ETT kink, leak, secretions, or PIE. The fix includes checking breath sounds, CXR, ETT, suction, and leak percentage. For high CO2, consider inadequate VT delivery, leak, or ETT displacement, and fix by reviewing the baby, CXR, ETT repositioning, and increasing VTE. This table provides rapid guidance for common ventilation issues. Remember these key clinical pearls. Activate leak compensation with a large ETT leak. Never raise Pmax blindly. Rule out obstruction, pneumothorax, and leak first. Always watch waveforms, not just numbers. Low PACO II of may be metabolic compensation, so check the pH. Finally, examine the baby first, and remember that serial assessments and a small ETT reposition can be more effective than ventilator adjustments.